So it is a pleasure to welcome you here. My name is Mike Wagner. I'm the President and CEO of Tufts Medical Center, and I'm here to introduce a special lecture for today. This is a topic all too familiar to all of us here in the Commonwealth, and the topic is that of the opioid epidemic. It's a topic that we are all too familiar with our patients here at the medical center, whether they be inpatients, patients who are being seen in the clinic. And it is a topic that we've, in collaboration with the university, have had many open forums and discussions around what we as a Commonwealth, what we as a medical center, what we as a medical school are doing to combat this very important problem. We've had some pretty lively discussions. We had Maura Healy here this past year, which was a great conversation, both here in the auditorium and then afterwards for lunch, in which she spoke with members of the School of Public Health, the medical school, and the medical center. Unfortunately, we see this crisis continue to play out every day. We do a daily safety huddle, and it is not unusual that we may hear of a story of somebody that has been found in a bathroom who has been found unresponsive because of an overdose. This is a topic that we talk about and we deal with on a near daily basis many times throughout the day. At the medical center, we've committed to do a lot and to combat this problem, from committing resources to build an addiction team, including the recruitment of psychiatrists with addiction medicine expertise, reducing the amount of opioid painkillers prescribed in our emergency room, in our primary care practices, introducing a curricula for trainees and for safe opioid use and safe prescribing practices, drawing on the recommendation of all state medical schools and bringing in local experts for assistance where needed, piloting novel methods for ensuring the safety of high-risk patients with opioid use disorder admitted to the hospital, training our faculty and residents in the use of medications like Suboxone to help managing withdrawal and drug dependence, and conducting research to better understand the interplay of illicit opioid use and things like infectious disease. We're proud of the work we've done, but it is just the start. There's so much work that we have to do in order to make the opioid epidemic, to improve it and to bring it under control. I'm glad that we were able to bring in a guest speaker today, and Dr. Skier is going to come up and do the introduction. Thank you.
Thank you, Dr. Wagner. I want to introduce you to Tracy Helton Mitchell, and I'll tell you a little bit about her background, and I also just want to tell you a little story about how we met and why she's here today. So Tracy was featured in a 1999 HBO documentary, Black Tar Heroin, The Dark End of the Street, and that was during her addiction to heroin. After the end of her filming, she actually completed rehabilitation in 1998, and since has dedicated her life to the care and treatment of people who use and are addicted to heroin. She entered school through an ex-offenders program where she earned a bachelor's of business administration and a master's of public administration. In addition, she's a certified addiction specialist and supervisor. She's also the author of a book, which she has here and will likely be talking about, called The Big Fix, Hope After Heroin, which is the inspiration for this talk as well, and has been featured by CNN, Anderson Cooper, Vice, The Huffington Post, New York Times, also some magazines recently. Glamour?
Yes.
Glamour, most notably. And she lives in San Francisco with her family, her 3 children, her husband, and flew in last night, so we have to give her a little bit of credit for a little jet lag. So just to give you a little bit of background as to how we met, I teach, this talk is being sponsored by the Department of Public Health and Community Medicine over at the medical school. And I'm Margie Skier. I'm an associate professor in that department, and I am currently the director of the health communication program in the Public Health and Community Medicine department. And I teach a course, actually I teach 2 courses for public health students and health communication students. One is called Snort, Swallow, and Smoke, Drugs and Behavior. If you can't guess what that was about, it's about drugs and behavior. And I also recently started teaching a course for the combined MD, MPH students called Fix, Addiction and the Opioid Epidemic. And while I was developing my curriculum, which I started teaching that course several years ago, I decided I wanted to make this more practice-based and make it a class that students can really understand what addiction is like and not just read about it or hear me talk about it. So I started looking into documentaries that students could watch and that we can use as a point for discussion in our classroom. And in Googling best documentaries on addiction, I stumbled upon Black Tar Heroin from 1999. It is freely available on YouTube, so anybody can just go and watch it. And as I was watching it, I thought this is the perfect documentary to really show the humanity and really what it's like for young people who are addicted to heroin. And after I watched the documentary, I started scrolling down on the YouTube page, and I noticed that even though the documentary aired in 1999, people were continually posting to YouTube about the documentary. And what I noticed was that a lot of people who were addicted themselves or who had family members and they themselves were struggling with having a family member who was addicted to heroin kept posting. And the one consistent thing that I kept seeing was that Tracy would reply almost immediately to people, within hours usually. And that was happening consistently, and even within days of when I had seen the documentary just a few years ago. So I thought to myself, well, wouldn't it be amazing if I could reach out to this woman to see if she would do a remote guest lecture for my class? And within minutes, she said, sure, of course. And that was how we met. So she now does annual and actually every semester practically, my students will watch Black Tar Heroin, and then Tracy gives a guest lecture. And she's always incredibly gracious and candid, and it just shows that from her postings how dedicated she is, and how even to this day all she wants to do is really help others to avoid or work through what she had been through. So thank you so much for being here, Tracy. We are thrilled and really honored that you're here with us.
Thanks. So I guess I'm double mic'd, which is fine. So I picked the right sweater for this auditorium. I'm excited by that. And also, you'll be excited to know that I don't use PowerPoints at all. I just talk. So I know at lunchtime after eating, and then the lights go off, and the PowerPoint. It's similar to the effects of heroin, but not as good. So I'm Tracy Helton Mitchell, Tracy Helton, and I'm a person who used drugs. So when we talk about people that have addiction issues, we really want to start out by using the term people. And I think so much has gone into the addiction field of labeling people with terms like addict or junkie or other different dependent. But I think, first of all, we have to put the person into focus. So seeing me here today, I work in San Francisco. I run $5 million worth of mental health programs for the county. I own my own home. I have 3 children. I have multiple degrees. I've written a book. I was on Dr. Oz. I also used to, which wasn't that exciting, but it's a whole other set of things. But I also was a person who used drugs. And when I say that I use drugs, I really use drugs. So I wanted to talk a little bit about my experience as an opioid user, sort of what got me into opioid use, then talk a little bit about my rehabilitation process. And then I work at the national level, the local level, and then also communicate with people regionally around sort of what's going on with the opioid epidemic around the country. And then I'm going to obviously take questions since you have a real live heroin user here. So I know that's always, and don't be afraid to ask me anything. You cannot embarrass me. My life was embarrassing enough. So there's nothing, and you can laugh at that. Don't be afraid. So I started out, growing up in a family that had alcohol abuse, but I didn't really know too much about. I'm actually a very, very sort of square kid who wasn't into sort of drinking or smoking pot or other kinds of things. I was really into fantasy and coding and gifted and talented classes. But I did get into compulsive overeating, and I was diagnosed as having depression when I was 12 years old. And I think there's a common theme as opioids being used as a mild antidepressant for a lot of people, and that's something that at the national level we haven't done a lot to really look into. So if you look in some of these areas of the country where it's extremely economically depressed and they have high rates of opioid use, a lot of time there's almost no mental health options available in those same areas. So you can see where, anecdotally people are reporting they're using opioids as sort of their de facto mental health care. So when I was 17 years old, I had my teeth pulled. And I remember the feeling of being prescribed, I think it was Vicodin, but I definitely remember the way that it made me feel, which was that it relieved all of sort of my burdens and my anxieties, and feeling like being, the things you feel as a teenager, being really, really concerned about what everybody thought about me. And so I was on these opioids when I had my wisdom teeth pulled for about 4 or 5 days, but I really, really liked that feeling. I didn't like smoking pot very much. I didn't like drinking very much, but I really liked the feeling of opioids. And I think that's it's a common experience among a lot of people who use opioids, because opioids feel really fucking good to some people. And so I think that is something that should be acknowledged. When you think about why people use drugs, there's reasons why people use drugs. And the first reason is, for some people, they feel really, really good. And so I went along into college. I tested out of almost my whole first year of college. I took 4 AP classes in high school, and I started using opioids again when I was in the University of Cincinnati. So what happens for a lot of people is they have access to opioids through the parents' medicine cabinets. So many of you, if you go home, well, maybe not so much this crowd, but a lot of people, if you go home, you've had surgeries and you have leftover opioids at home. And so teenagers and kids, that's a lot of times where they get them from, is getting them, or their own surgeries, leftover opioids from the medicine cabinet. So the amount of opioids that I had access to without ever going to the doctor and without ever going to the street was astronomical. So I remember in particular my friend bringing a bottle of morphine sulfate that was about this large, completely full to the top, and my friends and I taking this morphine sulfate, and then somebody had the idea that we should start injecting them. And I know that doesn't sound like a reasonable thing, like let's just inject them, but that's something that people who don't have a fully developed stop-go system, those are some of the types of things that people then think maybe that's something I can do. And so we ended up injecting them. And so the first time I went through opioid withdrawal, I didn't even know what it was. So I thought that was something that was in your brain. You made that up. It never happened until it happened to me. So I remember after 5 days of injecting morphine sulfate, I was sitting on the couch and I had the flu and I was shaking, and my muscles started locking up and I started throwing up, and I was begging my friend to suffocate me because I didn't know what was wrong with me. And he said, "Oh, you're a more experienced user is like, oh, you're just kicking." And I didn't even know what that was. And this is now it's been quite a long time ago, but when you think about the level of sophistication of some of the people who are using drugs today, it's not actually that far away. So when I go through the internet frequently and look at sort of the information that's out there about drug use, even today, a lot of the information is not accurate. And there's all kinds of urban myths about drug use and what's going to happen to you and what you can do to prevent an overdose. And it's still an uphill climb to get that accurate information out there. So to sort of, one of the issues that we had back then is an issue that occurs today, which is me and all of my friends use this very same syringe for 1 full year. So this is not injecting every single day, but this is when we would get opioids, we would inject drugs, and we had the very same syringe, and you were very concerned it was going to break off in your arm and that you wouldn't get to use it. Actually, you were concerned it would break off in their arm and you wouldn't get your turn, but that you were very, very concerned about this. And so I work on the national level with people in various states, and even in my own state in California, people not having access to clean syringes, not having access to usable syringes, people sharpening their syringes. I've actually worked with people that they manufacture their own syringes by going to Tractor Supply places and make them. And this is still going on in the United States today. This isn't 1990. This is currently going on where people have no access to clean syringes. So And we'll get to that in a little bit. So you can think about the health consequences of using the same syringe for over a year. So then I went to California on spring break, and I never left. And the reason for that was heroin. So I wish I could give you a better reason, but that's the actual reason was that I went. So I didn't have access to heroin the way people have access today. So today heroin is cheaper than a mixed drink, and it's pretty much anywhere. So you can get it delivered to you pretty much anywhere. It was much more complicated to get it back then. You generally had to go to urban centers to find heroin. Now I could get it delivered to me pretty much anywhere, either through the internet, ordering it on the internet, or the dealers have expanded. There's a whole book called Dreamland by Sam Quinones about the distribution of heroin through the United States. And then also, the heroin is much stronger today than it was then. In San Francisco around 1998, we peaked on our overdoses when the heroin would be around 38%. Now some of the heroin that they test coming out of New Jersey and different places can be up to 70% pure. So we're dealing with a whole different set of things. And then, so just to talk about sort of some of the things I experienced as a homeless junkie, and that's a term I can use, but we don't like other people to use that. I can use that about myself. So I got infected with hepatitis A, B, and C. And that is we have a current outbreak of hepatitis A in California because we have such poor sanitation and options for people who are homeless to use the bathroom. So in San Diego, there's a large outbreak of hepatitis A where people have died recently. So I cleared the hepatitis C virus, fortunately, but I've had 34 abscesses, so I almost had to have my leg. There's a large spot in my leg where the infection had gone between the two bone sections. So this is with access to clean syringes. This is because of the poor sanitation and the conditions I was living with, which was outside. So you can have alcohol wipes and sterile water, but if you're shooting up outside, these are some of the things you're dealing with. So violence, being a victim of violence, a woman on the street, also experiencing sexual assault. So there was a recent article that came out about sexual assault about women that use opioids, so that's very common. People trying to pimp me was another common thing. People trying to get me even more addicted to drugs. And I'm also a convicted felon. So I own a home. I run $5 million worth of programs. But in some states in the United States, I can't vote because of a $20 bag of drugs in 1996. And it's not like I wasn't Scarface. I was on the street. So I could go through the process of trying to get that case dropped, but that would cost me, thousands and thousands of dollars that I actually need for daycare. So that's a whole other set of things. So what happened? So I ended up going to rehab through an ex-offenders program. I got paroled through the county jail. So it's interesting. Some people say, well, jail, is that the reason why you got sober? Jail isn't the reason why I got sober. I didn't know any other option for getting sober besides for jail. So there were no other options at the time. It's not like people were going around saying, hey, would you like to get into rehab? There was none of that. So it was like jail was the portal, and you were lucky if you could get a bed in a service through the jail. So then I went through jail through an ex-offender program. The program that I paroled to had such poor outcomes, the city and the state pulled funding from it. So their success rate was somewhere, I would say, I would be liberal in saying it was 7%, 7% success rate. And so then I went into sober living that was run by the Salvation Army. So my sober living place was right where I used to use drugs, like literally the same block where I used to use drugs. And I lived there for 4 years. So now none of these systems I went through would be available to me now. No one is paying for a six-month treatment stay. You're lucky if you can get people in a 7-day or 28 days in treatment. No one lets you stay in a sober living facility for 4 years until you're ready to go. So rehabs used to be, back in the dinosaur years when I first got sober, it would kind of be as long as you needed to until you were ready to go. And you would start working and your rehabilitation process would be in the rehab. Now that's almost completely gone. The long-term rehab facilities, because there's such a huge volume of people trying to get into rehabs. And so that's very unfortunate. But what's also unfortunate is that we've really thrown outpatient treatment under the bus. Medically assisted treatments such as Suboxone and methadone in combination with outpatient treatments, which actually clinically have shown better outcomes. So when you ask people for what success rates for rehabs, it's really, really hard to get those because no one really knows. So if you ask the rehab to present to you what the success rate is, I wouldn't trust that. And we're not doing a lot on the national level to evaluate what makes a successful rehab and what doesn't make one. So what we do know works, and there's tons and tons of evidence through, SAMHSA, you can look it up, is medically assisted treatments and such as Suboxone and methadone. But in terms of the treatment community, those treatments are considered not clean. You're considered not clean. So there's a huge stigma in the rehab community and the recovery community around people who are on these medically assisted treatments, even though we know that those are the most successful treatment modalities. And so to sort of fast forward for me, I ended up volunteering at a women's facility where I ended up then being the manager years later. In my career, I went back to school. I got an addiction specialist credential. So I've worked in inpatient, outpatient, methadone, and a multidisciplinary team at a hospital, a methadone clinic. I've worked in jail with offenders, with male and female offenders. I've worked in the mental health field, and I've seen a lot of different things. But the current opioid crisis as it is now, I would have never, if you would have asked me when we started the first city-funded Naloxone program in 2003 that we would reach the point that we're at now with fentanyl in the drug supply, I would have never believed it. So the behind-the-scenes sort of numbers from the CDC for last year they're not completely finalized, but in 2016, between 60 and 70,000 people died of drug overdoses. That is way too many. That is a health crisis that we've never seen. And when you talk about the policy level, at the national level, what other public health crisis have you seen that has almost no participation from the population that they're working to help? So there is so much stigma attached to drug use, and there is so much stigma attached to, especially being a heroin user, there is almost no participation, nor have we been invited to participate at the national level to help form these policies. And that is a huge problem. So for my advocacy work, I've been contacted by people, various sections of the Trump administration. They don't contact me from their work emails, they contact me from social media because they are so concerned about getting involved with someone as controversial as someone talking about harm reduction. And that is a serious problem. That is a huge problem. And I'm not that controversial, I don't think. I mean, I have a sweater on, so. You can dress me up and take me places, and I know what to do. So I started working in one of the first city-sponsored overdose prevention programs. So we actually were teaching overdose prevention in 1999. So I got sober in 1998. So I have 19 and a half years sober. So sober for me is completely abstinent. But for medical providers here, one of the things that I wanted to specifically speak on was my experience when I had, so Thursday is actually my daughter's birthday. She's 10 years old. And so I went in I had to have an emergency C-section, and I was prescribed prescription opioids. And one of the biggest hurdles I've had in recovery is fighting with my providers about my opioid prescriptions. And what I mean by that was, even though I specifically had spoke with numerous medical providers in advance about my history with opioid use, fighting with them around, there was no taper plan in place for me, even though I had to remain on opioids for 3 weeks. There was no discussion around, did I need to meet with the outside specialist? So I was going through withdrawal just from taking actually less than prescribed. I was taking my opioids less than prescribed, and I was going through withdrawal with a newborn, shaking and my legs were twitching, and no one seemed concerned about this. And this was something that I have spoke with actually that healthcare system at length around the issues around that, around the fact that I'm trying to recover from having a C-section with a baby and I'm going through withdrawal. So I have had the experience of being a person who's been completely abstinent. And then in another instance, I had a miscarriage and arguing with the medical providers, if you send me home with that many opioids, I already feel like killing myself, and now you're sending me home with the means of doing that. So I had to argue with them to then go back and change my prescription. So now it's changed, but at the time they were giving me 30 Vicodin. I said, can you change this prescription to 10 Vicodin? And so that was a whole process I had to go through, and my husband had to assist me with that process. So, things are changing in terms of prescribing, but on the flip side of that, there's still so much room to go. So, addiction medicine has always kind of been this thing, a set aside. There's the addiction, and then their mental health and the physical health are in a silo, and we really need integrated care because it's all whole health. It's all part of our whole health. So even in the mental health field where I work at, sort of, is it treating the mental health before you treat the addiction issues, or treating the addiction issues before you treat the mental health? And I was basically told, for me to get my mental health issues treated, I had to get sober first. That's the only way that would work. And we know that that's not true. I mean, in the mental health field, there's a lot of evidence that if you give people meaningful activities, for some people just working, going to school, volunteering, something that makes them feel good about themselves, they decrease their drug use and they increase mental health outcomes. But we're not looking at a whole system of rehabilitation. We just treat incidents instead of the whole person. So fentanyl in the drug supply has really changed. It's changed everything. So on the East Coast, where you all are at, apparently, so they have what's called ECP, or East Coast powder. So it's really, really easy to put anything in those bags. So it can be baby laxatives, it can be fentanyl, it can be absolutely anything. Where I'm at in the West Coast, we have what's called tar, but tar more and more is being tainted. We're finding instances of tainted tar, but more than that, now there's fentanyl in every drug supply. So you go, well, you all may not, but people go to buy Xanax bars on the weekends and they're pressed with fentanyl. People go to buy, we just had a recent incident in San Francisco where one of the drug dealers decided to put fentanyl in the cocaine supply. So we had one fatality and numerous overdoses. So you can imagine if you're looking for a stimulant experience and now you have a downer and respiratory arrest, and that, numerous people ended up in the hospital. So no one is really safe from this. It's everywhere in our drug supply. And so, going to sort of our national strategy, I underlined sucks 3 times on my notes. I guess I really wanted to emphasize that it sucks. So here in Massachusetts, you all are doing a great job, and what's really going to have to happen is regional strategies. People looking at the geographics, the drug supply, the people who are using, the resources available, and looking at regional strategies. Unfortunately, we have regions in the United States, they're not willing to do anything. So it's very unfortunate that we still have no standing order for naloxone in many, many states in the country. We still have parts of the country where there is no access to clean syringes. So, harm reduction, when you think of it, harm reduction is sunscreen, seat belts, access to syringes. We want people from a public health perspective to be safe and have the tools that they need to be safe. Having a designated driver is a form of harm reduction. So from my perspective, I currently work, so I don't actually work, I volunteer, so it's a lot of work though. So I'm some people say that I'm obsessive and compulsive. I like to say I'm focused and driven around this issue. So I do a lot of work on the internet and through social media, working with people who have addiction issues. And that's a huge section of the population. So one of the things that we're seeing now is people who don't have any interaction with our needle exchanges in our public health facilities. So they're using literally in a vacuum, where the dealer and the few people that they're using with are the only people that they interact with on a consistent basis. And that's completely new for us. We're used to, if there's a bad batch of dope, we can send something to the needle exchange, we can put something out in the hospital, we can notify the media. But we're talking about people who no one knows that they're even using, and they're not interacting with anyone. So from a regional and then also national strategy, how do you reach people that don't come in contact with anyone that you have contact with? And so where a lot of that has been happening is social media. So there's forums. I'm one of the moderators on the opioids forum on Reddit, but there's also hashtags that people use on social media for people to anonymously get in touch with each other. So when we talk about working to try to work on the opioid epidemic, we also don't know how are we reaching these people, and a lot of research is not being done on that. So how can we reach people? So we can reach maybe the 40-year-old user or the 30-year-old user or the person who goes in for our services. But when we're talking about new users who traditionally have higher rates of overdoses, how do we reach those people? And then also on the national level, we don't actually know how many people are dying of opioid overdoses, because when you talk about people in the 50+ range, a lot of times what we're finding is the person will have an opioid on board, but they'll have a pre-existing heart condition or other things, and they're being coded as heart-related deaths when there's opioids on board, and the coroners do not want to necessarily code those as being opioid related. So when we talk about who is actually dying of opioid deaths, we really don't even know the whole scope of the problem. So if we think about increasing rates of opioid deaths in a 10-year period, it might be 500,000 people that die from opioid deaths if we don't get a handle on it. So, and then another piece of that is the naloxone prices. So when I started doing naloxone prices for the vials that we were using were around 33 cents a dose. So now some of the Avisio units are $4,000 a dose. So how are we combating that on a national level? So we only have so much money within our pools to purchase these units. So there has to be some kind of change. And these are some of the things that I'm just pointing these out. I don't really know what the solution are. When I ask the people on the federal level what they're doing, they're saying that they're worried about other kinds of price spiking if they do some kind of if they declassify it to over-the-counter, then it might change some other kind of price spiking. So I don't really know what the solution is. So sort of where we're at. So I wrote this book, but that doesn't have anything to do with my talk today. My book is just about my process of getting off drugs and then living. So it was really difficult. It's really difficult to stand up here in front of, now it looks like 100 and something people, maybe 200, saying that I'm Tracy Helton and I'm a former heroin user, because there's so much stigma attached to that. There's so much stigma attached to drug use. We love our drugs in the United States. We love our drugs. People use drugs, but we decide certain drugs, we don't love you using those. We don't want you using these drugs. And it's really, really complicated then to get help. And so, I was from the era of tough love, where your family was supposed to put you out on the street and have no more contact with you. I was lucky that my family didn't feel that way. But now we're doing more to work with a person where we're at. So really, harm reduction, where I work at, is working with a person where they're at. So I don't know what the solution is for you, but I'm really going to try to work with you in collaboration, in a strengths-based collaboration, to help you get to where you need to be. And that's really sort of the core of my talk, is that no one in this room has all the answers for that patient or that person that presents. But if we can have a collaboration where that person, a lot of times the solutions are inside them. So really, harm reduction is about drawing out the solutions. What have you tried before? What are the things that have worked for you in the past? I can say for myself that if it wasn't for a caring medical professional talking to me about my incident with my leg, so it's interesting, one of the doctors who told me, you did a really good job trying to take care of your leg, but now I actually need to do this, this, and this. And acknowledging that for me, that's on one of the doctors that I work with on a regular basis, and my staff were actually in his office. So that's Dr. Barry Zevin. And then also, the social workers that would volunteer their time at needle exchange, or the people would tell me, you deserve more than this. This is something that you need. You deserve more than this, or giving me a sandwich, or reaching out to me, or being compassionate. Because compassion is really, if the opposite of addiction isn't necessarily recovery, the opposite of addiction is connection. We're all searching for connection with someone. And we need to separate people so the connection that they have is someone besides for the drug dealer, that they have an opportunity to be open without judgment with us and discuss their issues with us. So I have about 22 more minutes. I really wanted to answer people's questions, if people had questions. Thank you. Mike?
Questions?
Hi, thank you for being so honest. I'm a PA student here at Tuft, and I want to ask you if you know what happened to your friends that you were using drugs with at the time. and if you had any buddies, and if you know what happened to them.
So at the time when I was using drugs, so I was using what we call the era of AIDS. So I was told many, many times that my death would be welcomed and that AIDS was God's retribution, and so all of us should die. So I actually lost a lot of my friends to HIV, but there is, and overdoses, but there's sort of a myth, particularly around heroin. So there's a black tar heroin runs. At the very end, they run this statistic, which is absolutely not true, that says only 1% of heroin users get clean and stay clean. So if you look at the SAMHSA data, there's 4.5 million people who've tried heroin in the United States, but there's somewhere, and you know the data is actually underreported, but there's probably around 800,000 heroin users in the United States at any given time. So that means the majority of people who've used heroin actually quit. So most people, if they can survive fentanyl, if they can survive endocarditis, if they can survive, you know, the sepsis or whatever, they can then get sober and live a productive life. So our job is really to help people get past that point and give them the tools that they need so they can then live their best lives. So whatever that is. So I have some friends, particularly who I was just at one of our public health clinics. Someone I used to use with regularly, I ran into her. She was a nurse there at the clinic. So she's a public health nurse. A lot of us have gone on, there's a subset of us, that the ones that survived, who have gone on to then do really well. I have two or three friends that are nurses, a few friends that are therapists, and some people, you know, they're moms or they're artists or just living their lives. But I look at, if there wouldn't have been someone who was there sort of holding the doors open, working with us around our public health issues, you know, what would have been taken away from the community? So that's sort of my experience being a drug user in the 90s, where, you know, we worried about overdose, but not the way that you worry about overdoses today.
Tracy, I actually video chatted with you a few years back in Margie's class, so it's really nice to see you in person, and thank you for coming. So we do a lot of research on harm reduction strategies, and one of our research was on abscesses amongst injection drug users in Boston, and we found that women that were working in sex work actually had a much higher odd of having abscesses than men, and we're sort of trying to figure out if it's like a social dynamic sort of a situation where their boss prevents them from having access to needle exchange or anything along those lines. So I didn't know if you had any clients or experience or friends that you know went through something like that.
So I have some experience with sex work that my personal experience, and I'm not really embarrassed to say that. And I would say that there is an extreme amount of encouragement for women who are addicted to opioids to get involved in sex work because of the sort of untapped financial resource that it then provides for the person that they're with. So I was, from the moment that I got really heavy into drug use, I was encouraged over and over and over to get into sex work. But a piece of that is also, if I'm the main source of income, then I don't have time to then go seek out services because that person can't have their drugs if I'm off somewhere at the hospital. So when I had hepatitis A, I was still encouraged to be involved in sex work. When I had infections, I was still encouraged to be involved in sex work. And so that was a very small piece of my existence, but having worked in a sex worker clinic, it's very, very common. And so one of the other issues that we have, if you talk about specifically gender-specific services, when it comes to recovery, we find it's very, very challenging for people, especially women who have children, to participate in recovery because there's so much pressure for them to go home to their children or get their children back. And so when I was in rehab, there's a story in my book where the women would be on the phone crying, encouraged to come home, to leave the rehab early, to come home to take care of their kids. You need to come home and take care of your kids. You need to leave the rehab and take care of your kids. So really, there's so little opportunity for us just to slow down and say, I need to take care of myself. And it's the same thing in society today. There's very little, if you have a cold, how many of us say, you know what, I think I'm gonna stay home for 3 days. I'm just gonna take care of myself. So when you talk about a person who has a soft tissue infection, even though we know it can lead to sepsis and all these other things, it's really hard for a person to say, you know, my drug habit has to stop. I have to just stay home and take care of myself.
Whether or not you've ever had Narcan, could you talk a little bit about the time period between administering Narcan and when the person is released from health services, kind of what that looks like from their perspective and what we can do in that short time frame to do the most good?
So in the dinosaur junkie era, when I was using, they Narcaned me and they strapped me to a gurney for 45 minutes, and they would give you the highest dose possible, so it'd push you into, you know, such severe withdrawal, and then they would release you then you would leave against medical advice 45 minutes to an hour later. So that was my experience with Narcan. And the police telling me, you're either going to get this Narcan or you're in jail. Well, I was conscious. They shouldn't have given me Narcan, period. So they gave me Narcan because I was responding, because I had saved someone else from an overdose, and the police came. So that was my experience with Narcan. So when you think about having an intervention with someone, I think that having an intervention with someone who has been Narcan and had an overdose, how are you feeling right now? Having a connection, like, what were the circumstances leading up to that? What can you take away from this experience? What could you do differently? What are the resources that you have available? You have this time. What are the resources that you've used in the past? Like, can you carry naloxone with you in the future? Is that something that what is the patient willing to commit to? And I know it's having naloxone when you have any kind of opioid habit, it is horrific. It is terrible. They have these articles saying that people are having Narcan parties. No one's having Narcan parties. No one's having Narcan parties. I mean, it was absolutely, it was horrific. It's 10 times worse than withdrawal, and withdrawal is horrible. So really, intervening with the person and finding out, giving them resources, linking them to peer advocates is a huge piece of that. People who can understand what it's like. I overdosed, but that was actually the beginning of my using, not the end. But linking people to resources when you have that window of opportunity that's available, and realizing that you don't know what you can't necessarily change the outcome, but you can open up a bridge to a conversation with someone.
Other questions? Okay.
Hi, I'm Liz. I'm a nurse on an inpatient floor here at Tufts. We have a lot of patients that come in with abscesses, that have pain medication issues. We're treating patients while they're currently addicted to using. Is there any recommendation that you have for us as healthcare providers in order to help them, but also not to, like you said, when you had your C-section and giving too much or too little, like, is there a recommendation you would have for the nurse or the doctor to know, kind of how to treat those patients appropriately?
So I think one of the things we need to realize is, in the healthcare field, is how much stigma is attached to medically assisted therapies like methadone and Suboxone. So in a situation like that where a person has, they may have 4 abscesses and their legs are falling off, in the community they're told that this isn't a good option. And I think as a system as a whole, we need to come back and really be able to present those in a way that's compassionate. And then also, I can just speak for myself, having abscesses is really, really painful, but we know there's also the mental piece of that too. And I think that getting access to then mental health services and also peer-based services. So I just was recently called in. So the person had endocarditis, and they had a PICC line, PICC IVs for their antibiotics. So they needed multiple course of antibiotics because they had endocarditis and MRSA. And so they had me, and this was just a favor. Someone asked me if I'd be willing to come in and talk to the patient bedside. I think we need to do more of that at a hospital level. So in mental health, we've started all these programs where we send people into inpatient psych. So I was just the director of a mental health respite that was located on the SFGH hospital grounds, so it was adjacent to there, so people could go there as an alternative to hospitalization. So really getting peer advocates within the hospital systems that can go and meet people bedside and discuss what their options are with people and how they're feeling and advocate for them is a really important piece. Peer navigators, there's all kinds of clinical evidence to show how important that is. So, but also linking them to someone who can meet with them on the outside, and that's sort of a piece that's really missing. It can't just be the social worker. There has to be another social piece of people that they can meet with when they get out of the hospital. Those are just my recommendations, which I made to someone through social media in the Trump administration. So we'll see. The opioid plan is a month late. We can tell it what a priority it is. Don't be embarrassed. Don't think I'm embarrassed. Don't think I'm embarrassed either.
So I'm not really sure about this policy, but I know CVS just instituted one about not issuing more than 7 days worth of opioid supply, and I was just wondering what your thoughts were on that.
So there's two pieces of that. Pain patients have been thrown under the bus in this whole process. So we already know that 3 days post-op, opioids isn't necessarily the best course of medications for some people, but we already have so many people that are on these medications, and we really haven't done a lot to figure out what is going to help them. So I have a lot of friends that have been chronic pain patients for years and years and years, and now they're going in being told that their medications are cut off, or they're being kicked out of their pain clinics. So in terms of a national strategy that really looks at the whole landscape, we're just a reactionary strategy. We're just going to cut shit off. We're just going to cut this and cut that. And so I don't necessarily know in terms of holistic care for an individual if that's necessarily the best course of action. But unfortunately, we have people who are just making these sort of blanket decisions for everyone. So we're not really good. We're not good at doing sort of looking at the landscape for the whole person. We're really good at just sort of making blanket decisions that we think are going to benefit a few people and not worry about so much about the other people. But a whole other piece of that I wanted to bring up here is that even in places where selling syringes is legal, it can be at the discretion of the pharmacist to refuse to sell syringes. So even in places like Massachusetts, New York, California, where it is legal to sell syringes, we have pharmacists who refuse to sell them. So that just tells you sort of where we're at. So our policies that we make are sort of hodgepodge. It works for you, but then it doesn't work for you. So we're not doing any kind of comprehensive strategy. You're getting your exercise today. Fortunately, it's air conditioned in here. I didn't realize it's gonna be a furnace in Boston.
Thank you for your time today. I was just wanting to know how effective you think programs like NA and AA are for opioid addiction. I know it's a loaded question.
That's my reaction. So I personally use 12-step programs. 12-step programs are actually part of the problem. It's not the program itself. So the program itself says, we're here to help anyone who wants to stop using or stop drinking. It's actually the members that are the problem. So people say, if you're on Suboxone, you're not really clean. Well, they're going to a meeting because they're trying to stay off drugs. You're on methadone, you're not really clean. You're using cannabis maintenance, you're not really clean. You shouldn't be here. And it's the members that are actually the problems. And there's so much stigma attached to MAT. And then a whole other piece of that is we really love, or we're not we, but there's a big push towards naltrexone and different kinds of interventions that are complete abstinence-based, even though we know naltrexone doesn't work for a lot of the population. There is no intervention in terms of opioid use that is across the board successful. So 12-step might work for some people. Vivitrol shots might work for some people. Just going back to work might work for some people. The number one way that people quit using drugs is on their own without rehab. All the evidence shows that. So people are tapping into different systems that help them. If you're going to a 12-step meeting, obviously you're trying to get help. So I would recommend anyone in the social work field, if, you know, it used to be sort of like a blanket thing, we'd say go to 12-step or whatever. You really have to prep people for what might happen. And so some people say, I had this whole thread on my Facebook. I always like to create these discussions and I back out of it because it's too much even for me to watch. It's just a train wreck. Where we had talked about 12-step and opioid use and people getting on these therapies. I mean, it can be helpful, but it's only as strong as the people in the room. If you have people in the room that are helpful, it's going to be a good experience. If you have people in the room who are going to stigmatize you, then it's not necessarily a good experience. So I would say you didn't get, if your dope dealer told you they were out of dope today, you wouldn't be like, well, I'm done with dope for my life. You would go to another dope dealer. If you go to a meeting and you don't like the people in the meeting, try another meeting or take it with a grain of salt. There's also Life Ring, which is an alternative to 12-step, and there's Smart Recovery, which is more evidence-based, helping people work around individualized goals. Life Ring has an online component. Smart Recovery is, you know, it's a whole nother set of things that used to be called Rational Recovery, kind of went out of there. So there are alternatives to 12-step out there, but the media tends to focus on just 12-step. So the Life Ring Recovery book is actually just practical things to discussing, and you work through it, like, do you get triggered going to the ATM? What are your triggers? Is it smells? And really cognitively thinking out what all your different triggers are. And that can be really helpful because a lot of times when getting off opioids leaves such a huge hole in your life. If your whole life has been focused around the getting and using and finding ways and means to get more, you take that away, it's like your first love left. Not only did they leave you, they whooped your ass before they left and took all your money, and they left you, and it's like, you can't stop thinking about them. And so if you've been doing something every single day for 5 years, 3 years, every single day, it takes a while to stop thinking about it. And our opioid users, they think they're a bad person because they're thinking about it. Or why am I still thinking about this when it's so horrible for me? It's like, that's natural. I mean, so if you talk about drug use as a medical behavior, human beings want to be pulled into something. They don't want to be pushed into something. So if drug use is a medical behavior, if you're working with a person who's diabetic and has a terrible diet, if you tell them, stop drinking sodas, that doesn't go over very well. If you go over sort of the reasons you should stop drinking sodas, the kind of things that they're doing to their health, providing people with evidence, it may take a while, and maybe it'll work and maybe it won't, but maybe they'll stop drinking sodas. So it's just another health behavior where we have to provide them with as much information, and some stuff is going to work and some stuff is not going to work depending on the individual.
I think we have time for 2 more quick questions.
Thank you. I was wondering if you could talk just a little bit about your decision to be so publicly open about your experience and how you came to that decision and how that's affected you and whether, you know, I think we don't see that many people from your experience who speak publicly and from their direct experience. And would you encourage more people to do that, or do you think it's a hard thing to do? Anyway, whatever you think.
I kind of had no choice. So I was in this movie I was high on drugs and I let them film me for 2 years. And then I got off drugs and I was sober for a year and they said, this movie's coming out. I said, oh shit. Because I agreed. And they didn't pay me. I agreed to be in this film. And so now everyone's going to know that I was on drugs. So I actually had a discussion around trying to get myself taken out of the film. And they said HBO has all these high-powered lawyers. That's never going to happen. So I decided to make lemonade out of lemons because it really sucked. But I really thought when they agreed to film me for Black Tar Heroin, I really thought I'd be dead, so I didn't care what was going to happen with the film. Like, there's no reason why I'm here today. If you were to look at me, even the filmmaker, there's a scene in the film where I'm doing laundry, and I asked him, why am I doing laundry? He said, because all you ever did was shoot up, and we had to film you doing something else, so we gave you money to do laundry, because all I ever did was shoot up. That's all I did, was get drugs and shoot up. And so I decided I'm just going to be really open about my life because maybe it'll help someone. So my passion is really helping other people, and I feel like we're really doing, people in the recovery community, a lot of us are doing a disservice by being anonymous because there's really people who can learn from our example. There's so many people I know that are doing so well, and they used exactly like me, And so I kind of feel like my life has been a reprieve from something, so I might as well turn it for something good. But, and I also feel like it's really important to see when you see that patient, like I was homeless for on and off for 6 years. I was 120 something pounds, completely skeletal, had 34 abscesses, had all these different health problems. When you see me in the ED, that person 5 years from now could be doing the things that I'm doing. I'm not unique. So I think it really inspires people, and it changes people to hear those stories.
This last question.
Dang it.
Thanks very much, Tracy. Just curious about your thoughts on for-profit MAT programs or substitute programs. There's more and more popping up. Your thoughts of the for-profit versus not for-profit?
So I can say I won't name names, but I can say there's a huge difference. So I worked on a multidisciplinary team at a hospital that had a psychiatrist, nurses, addiction counselors working with the highest need people in the system on methadone. And people that they said could never get better, we saw a lot of them get better. I think that's methadone in particular, there's this idea that the person getting methadone is like the person slumped over going to get their dose. And we had a lot of, high-powered people that, some of the people made more money than me at a certain point. I was a little bitter, but they'd come in, they would get jobs, and they would do really well. And we've thrown methadone sort of under the bus. So now these private clinics take over, and a lot of the things that people go through are just completely inhumane. The amount. So I worked with a clinic who I won't name. I didn't work at there. I would never work there. But they used to make people who had been clean urines for 16 years come in they'd have 7 take-homes, 50 minutes of counseling 4 times a month to maximize their billings to Medi-Cal. That's not humane. That's not humane. So our systems switched to buprenorphine because it's office-based and so we want to get away from the clinics. One time I was in the elevator with one of the methadone patients and he was saying, I've had to dose here every day for 8 years because he never had clean urines. And I was sitting there thinking, I don't know how would that motivate me having to do the same thing, like every day for 8 years, like treating people. The federal guidelines need to be changed around methadone take-homes. I understand it looks like Kool-Aid. We're worried kids are going to overdose and stuff like that. But Suboxone is everywhere now too. So really the private clinics tap into people that are desperate and want to be separate from sort of our other sort of low-income patients. That's sort of the pool. And they also capitalize on our public resources. So I don't know what they call mass care or we call it Medi-Cal, tapping into that. But it's not really with the patient's well-being in mind. It's with profits. But I have to say that if it wasn't for some of these private clinics filling the gap in some of these places where the public clinics are just not going to get in. I mean, there's parts of the country where the only place that you have access is at a public clinic. So we actually have, as a total side note, our county, the same doctor who treated my leg, started a buprenorphine on demand for homeless people in San Francisco, where homeless people can go in and get on buprenorphine that day.
So I'm sorry we don't have time for any more questions, but Tracy, thank you so much. I think it's so important that we continue to hear stories of people who have been sort of in the throes of addiction and then have really just showed how successful life can be, and it really does give hope. So we need to hear more stories like that. So I want to thank everyone for being here. Lots of students, nurses, everybody. Dr. Wagner, thank you. And Dr. Must, our Dean of Public Health and Community Medicine, or Public Health and Professional degree.
Thank you. I appreciate it. Thank you. Can I get a picture with us? Would that be okay?
Absolutely.
Could you?